Well, welcome everyone. Thank you for joining us for today's webinar program, the Gut Bladder Connection, Illuminating Chronic Urinary Conditions with Advanced Stool Testing, brought to you by integrativeppractitioner.com and sponsored by Diagnostic Solutions. And with that, I'd like to briefly introduce our speaker for today. Dr. Amy Rolfsen is a naturopathic doctor and medical consultant. Her area of clinical interest and expertise are women's wellness, children's health, immunology, and gastrointestinal health. Dr. Rolfsen is continually working on mastering her craft. She is drawn to gentle, non-invasive techniques and will incorporate a combination of nutrition, botanicals, Chinese medicine, manual therapies, energetic therapies, and pharmaceuticals, tailoring treatment plans to each individual. And at this time, I'd like to welcome Amy.
Thank you for the introduction, and thank you everyone for being here. It means so much to me and to us all at Diagnostic Solutions that you took time out of your day to be here with us. I designed today's webinar to be very clinically relevant, and I want you to be able to apply the things you're learning today to your practice today, tomorrow, this week. So basically, my hope for you is that after this webinar, you will feel like you have the tools and confidence to treat chronic urinary conditions and gut health competently in your practice. So today we're going to talk about chronic urinary conditions as they relate to gastrointestinal health. Because I want to make this webinar clinically relevant, I won't spend a lot of time discussing the basics of urinary concerns. I'll really be focusing in on how GI health can impact urinary health, what to look for specifically on a stool test that is likely to be contributing to urinary conditions, how you might approach your most challenging cases in clinic. I'm going to make sure we leave time for at least one case and lots of time for questions. Chronic urinary conditions come in all shapes and sizes, and chances are you've already had some patients in your practice that have at least low-grade urinary concerns. There's a huge degree of symptom overlap between the first three conditions I'm going to be talking about. Many researchers have actually hypothesized that these conditions share pathophysiology and all represent a spectrum of the same condition. Really important for all the first three diagnoses is that UTI is ruled out. In the majority of cases, there is a history of UTI, but there shouldn't be evidence of current infection. So interstitial cystitis, or bladder pain syndrome, ICBPS for short, is defined as an unpleasant sensation, pain, pressure, discomfort, perceived to be related to the urinary bladder, associated with lower urinary tract symptoms for more than 6 weeks duration in the absence of infection or other identifiable causes. So IC, or interstitial cystitis, tends to have an inflammatory component, while BPS doesn't. And then some practitioners refer to this whole condition as hypersensitive bladder, or HSB. Overactive bladder, or OAB, is a condition characterized by overactivity of the detrusor muscles, the muscles responsible for emptying the bladder. And then to differentiate between ICBPS and OAB, generally IC patients may void their bladder to relieve pain, whereas overactive bladder, or OAB patients, may void their bladder for fear of incontinence. It's not going to be the same across the board, but generally speaking, that can help differentiate. OAB may also respond to prescription antimuscarinics, whereas ICBPS won't. Chronic prostatitis, or chronic pelvic pain syndrome, has very similar symptoms and signs to ICBPS, but the patient may have a chronically enlarged prostate. In all three of these conditions, you may see increased frequency, but you won't be likely to see an increase in volume. So roughly 100 mils per void is what you'll see here. And this can help differentiate between these three conditions and polyuria, which is an increase in urine production. And then in practice, I'm sure you see a lot of patients with chronic recurring UTIs or chronic low-grade UTIs. And these can be broken down into either relapse, which is a recurrence of the same organism, or reinfection, which is serial infections with different organisms. So relapse is more complicated than reinfection and often involves biofilm. And then you may also see patients with a chronic low-grade UTI that just lingers on and on, kind of maybe gets better and worse, but never totally goes away. And we'll talk a little bit later on about urine cultures, biofilms, urine PCR, which will come into play for these patients. So differentiating between these conditions is really important for your clinical success. And I'll talk later on about how we can use some of our therapeutics to actually help distinguish between the chronic urinary conditions. So briefly on symptoms, here are the most common symptoms you'll see with these concerns. Urgency, frequency, and pain are common to all these conditions. With any degree of symptom severity, you're likely to also see social emotional signs and symptoms. Chronic urinary conditions can be incredibly debilitating and can result in a wide range of social emotional symptoms such as isolation, depression, anxiety, and difficulty maintaining relationships. What's interesting here that we'll see later on is that physical and mental distress also significantly predispose to and exacerbate urinary conditions. In terms of clinical signs, here are a few things that may be available to you. And again, I'll stress that within the chronic urinary conditions, it is usually a diagnosis of exclusion. In ICBPS, the average time to diagnosis is 3 to 7 years. And many people you see in practice will be hearing the words interstitial cystitis for the first time in your office after years of symptoms. For patients with ICBPS, 16% only will have Hunner's lesions on cystoscopy, and I've heard as low as 10% in some research. Some may have glomerulations, although these are not sensitive or specific for IC, so the majority of your ICBPS patients will have a negative cystoscopy. In OAB, there may be known increased tension or activity of the detrusor muscles. In chronic prostatitis or CPPS, there may be mild to marked enlargement of the prostate. I would say that in my practice, the majority of patients that come in with chronic urinary conditions will present without a solid diagnosis. They may come in with a concern of recurrent or chronic UTI, having been treated repeatedly with antibiotics with little or no success or temporary success. And they may also report that they had negative urine cultures. Either way, when it comes to differentiating between urinary conditions, I don't take anyone's word for it. I always want to see the labs and imaging myself. Historically, urine cultures were considered positive at 100,000 CFU or colony-forming units per milliliter. And then more current guidelines consider a urine culture positive at 100 CFU per milliliter if the patient is symptomatic, and these would represent more complicated UTIs. And it's worth mentioning to my Canadian practitioners here, be careful about your units. Many Canadian labs report urine culture results in CFU per liter, not milliliter. The urine cultures our patients have access to may not always show us the whole picture. Many of the microbes in question don't culture well, or they'll be found in levels significant enough to cause symptoms, but not high enough to be considered positive for a diagnosis of bacteriuria. In my more resistant urinary cases, I am often running a urine PCR test and a repeat culture to rule out low-grade infections. So let's dig into the gut-bladder connection. Because we just have an hour, I'm going to go over each concept very briefly and highlight some of the important research. But just know that there is so much more out there than what I'm presenting today. This webinar will just skim the surface. And one message that I really want you to take away from this webinar is this. GI imbalances don't always manifest as gut symptoms. Urinary conditions are a great example of this, but this concept extends way beyond the urinary tract. I want you to think of gut health in every single case, not just the ones that are obviously gut related. And I cannot stress enough how much this will benefit your practice and your patients' results if you do take a deep dive into their gut health. So I'm going to start out by pointing out some classic changes to the microbiota that you might expect to see in your chronic urinary conditions. Then we'll talk about the uropathogens, the organisms that can cause inflammation and infection in the bladder and urinary tract. We'll talk about inflammation and histamines. And then next we'll talk about intestinal hyperpermeability, as well as hyperpermeability of the bladder lining and urothelial cell damage. Then we'll investigate crosstalk between the pelvic organs and a little bit about pelvic floor dysfunction, which is really common in chronic urinary conditions. And then lastly, we'll talk about the brain-gut-bladder axis, how the gut and bladder can influence the nervous system and how our nervous system can affect the GI tract and bladder. Oh, put that in the wrong spot. Okay. So there is a big connection between IBS, irritable bowel syndrome, small intestinal bacterial overgrowth or SIBO, and chronic bladder conditions. We see in multiple research studies that IBS and functional dyspepsia are very common in patients with overactive bladder. Usually around 1/3 or more of patients with OAB reported either IBS or functional dyspepsia. 40 to 60% of patients with ICBPS have at least one comorbid condition, the majority of which is IBS or other GI symptoms. And then fibromyalgia, endometriosis, asthma, and RA are also common. Now, in a 2008 study, patients with IC and GI symptoms underwent a lactulose breath test. The majority, 81% actually, were positive, suggesting SIBO. The participants were treated with a 10-day course of rifaximin followed by a prokinetic, and the GI and urinary symptoms improved. This strongly suggests that regardless of GI symptoms, microbiome and gut terrain play a role in IC. Let's talk a bit about distinctive differences in the microbiota that you might see in chronic urinary conditions versus healthy controls. So in ICBPS, you may find lower levels of lactobacillus in the urinary microbiota. You'll also see changes to normal flora in the GI tract. In this great study by Braun-Meyer-Fleming et al., you'll see that they have concluded that pelvic pain in IC is likely modulated by the microbiome. They found a signature pattern showing low Faecalibacterium prausnitzii, low levels of some Clostridia species, some Escherichia species, and a number of other distinctive deficiencies characteristic of IC. And we'll actually look at one of their graphics on the next slide that's really beautifully done. Patients with chronic prostatitis, chronic pelvic pain syndrome, consistently had lower levels of Prevotella, a normal flora, compared to controls, as well as multiple bacterial overgrowths. In the study by Magruder et al., investigates the link between gut microbiota and UTI. The findings suggest a really strong link between Escherichia and Enterococcus populations in the gut and UTI. The findings for other Uropathogens was less clear, but their conclusion was that modulating the gut microbiota may be a potential strategy to prevent UTI. So here's that graphic I was talking about from the same article by Braun-Meyer-Fleming et al., illustrating the signature stool microbiota differences found in ICBPS compared with control. On the left here, IC is represented by green, control by blue. On the right here, again, IC is green, control is red, and you'll see those represented around this beautiful wheel. And here we see a snapshot of the GI map. This is a quantitative PCR or DNA stool test that is really great for picking up organisms, whether they are culturable or not. And here we're looking at the normal flora section. Everything here listed in yellow and also in the black, but marked less than detection limit or less than DL, is a deficiency. In this particular patient, we see a marked deficiency in the abundance at the population or phylum level. We actually see a normal population of Faecalibacterium prausnitzii that we talked about a few slides back as being fairly typical to see low in IC, not in this particular patient, however, but we do see deficiencies of both Clostridia class, and I've already circled that one, but Escherichia genus. When I see a stool test with such widespread and significant deficiency like this, I am also questioning the health of the GI terrain and the gut barrier. With low normal flora, we often see changes in the health of the intestinal epithelia and hyperpermeability. We may also see inflammation and loss of immune tolerance, not to mention significant digestive insufficiency, including low diamine oxidase levels. So let's take a look at the uropathogens next. This is where it really starts to get interesting. So quite a few studies I came across had the same conclusion. In patients with ICBPS, at least half had a recent history of UTI shortly before onset of IC symptoms. Magruder et al. Conclude that uropathogenic gut abundance is a risk factor in the development of bacteriuria and UTI. Loya et al. Found that E. coli can induce urothelial apoptosis. Since more than 50% of urinary tract infections involve E. coli, this is very significant. This means that E. coli UTIs can lead to degradation of the bladder barrier function and can lead to long-term bladder issues. Now, here's an interesting piece. Nickel et al. Recently found that in patients with ICBPS, the likelihood of finding fungi in the urine increases with severity of urinary symptoms. In practice, I do find candida and other fungi on stool tests for my patients with bladder symptoms as well. But when you think about ICBPS and the diagnostics, one of the requirements was that you do not currently have a UTI. So if you're finding fungi in the urine of patients with ICBPS, is that the correct diagnosis or is it not? So that brings a lot into question. Now on this slide on the left, I've got a list of very well-regarded uropathogens. So this is a pretty solid list. On the right is where you'll find them on pages 1 and 3 of the GI map stool test. And note that many of these are inflammatory gram-negative organisms and will have the potential to produce LPS and or histamines, potentially CDT. Most of them are also potent biofilm producers, which can predispose to chronic gut and urinary colonies and increase resistance to treatment. So this leads in naturally to inflammation. LPS, one of the inflammatory compounds produced by gram-negative organisms, can be absorbed into the urothelium, the cells lining the bladder wall, leading to inflammation of the bladder wall, increased visceral sensitivity and pain reception, local edema, and subsequent histamine release. Now, briefly, here is the intestinal health portion of the GI map showing a patient with inflammation. Here we've got calprotectin, which is a protein put out by neutrophils. We see this calprotectin slightly elevated, just above range, and this is quite a bit lower than what you would see in IBD or inflammatory bowel disease, but could cause significant issues. And as we'll discuss later, inflammation in the GI tract can cross over to other pelvic organs. So we just discussed how inflammation in the bladder wall can induce the release of histamines. Now we'll discuss how histamines can impact bladder symptoms. We'll also discuss some organisms that can impact histamine levels on the next slide. We discussed this concept briefly when we were looking at the deficient normal flora. Dioxidase deficiency is common with damaged epithelial cells. DAO is one of the enzymes responsible for normal degradation of histamine. When levels are low, histamine levels can build up. DAO is one of our brush border enzymes, the enzymes produced by the intestinal epithelial cells. When the epithelial cells are damaged, like in normal flora deficiency or secondary to inflammatory dysbiosis, you may see histamine clearance issues cropping up. Now the really juicy stuff. Higher levels of mast cells, the white blood cells that contain and release histamine, are associated with ICBPS. And these were specifically mast cells in the bladder. Histamine receptors are significantly elevated in ICBPS, meaning that the effects of histamine will be more pronounced. Histamine increases the contractility of the detrusor muscles, so this is significant in overactive bladder. Histamines also increase pain perception and inflammation, and contribute to hypersensitivity to bladder distension. So in chronic urinary conditions, we may have increased release of histamines from mast cells in the bladder. We may have lower levels of DAO, the enzyme that breaks histamines down, but we may also see an increase in organisms that can either produce histamine or induce the release of histamine by destabilizing mast cells or other histamine-containing cells. On the next two slides, I've pointed out some organisms that can affect histamine levels. The green arrows indicate organisms that can potentiate histamine release under the right conditions. Blue arrows denote the potential for histamine production. So here we've got the 6 pathogenic E. coli here. They are all fairly potent histamine release inducers, and then some of them can produce histamines. Escherichia genus, which all the E. coli fall into. Here on the next page, we've got our histamine producers, Enterococcus, Morganella, Citrobacter Klebsiella proteus, and then 2 quite potent histamine release inducers. So we've got the Pseudomonas genus, Aeruginosa would be the same. Down here at the bottom, Candida genus. Candida albicans would be the same, but I cropped it off at the bottom of that slide. And now note the similarity between these two lists on these last two slides and the list of uropathogens. They are almost identical. Now let's talk about hyperpermeability. Leaky gut, leaky bladder, maybe leaky blood-brain barrier too. Now here's a quote from a 2011 article by Parsons referring to IC, OAB, chronic prostatitis, urethral syndrome, and gynecological chronic pain. All of these patient groups actually suffer from the same bladder disease. This disease results from a leaky bladder epithelium and subsequent potassium leakage into the bladder interstitium that generates the symptoms of frequency, urgency, pain, or incontinence in any combination. Here, Parsons is alluding to the concept that all of these chronic pelvic pain syndromes are actually different points along the spectrum of the same condition. The bladder is not to blame here. It is an innocent bystander in a chronic inflammatory condition. Moving on, we see that increased intestinal permeability leads to increased nociception. In clinical practice, we'll see this is applicable to gastrointestinal pain perception, pelvic organ pain, as well as generalized body pain. Next, we see that changes to urothelial cells can contribute to the pathogenesis of ICBPS. We see altered mitochondrial function of the urothelial cells. Now, we discussed this point earlier, but it's worth repeating. E. coli can induce urothelial apoptosis, leading to hyperpermeability of the bladder lining. And we also saw how LPS and histamines can predispose to bladder lining changes, pain perception, and inflammation. Now, here on the GI map, we see fecal zonulin elevated. This is our add-on marker for intestinal hyperpermeability. There we are. With hyperpermeability, we may also see deficiency of normal flora, low secretory IgA, potentially even low elastase 1 or pancreatic enzyme output. Now, hyperpermeability is also extremely common in the gut secondary to pathogenic infection or significant overgrowth of candida, parasites, or inflammatory bacteria. Now I'd like to talk about an interesting concept. Visceral crosstalk refers to how visceral organs can impact each other through sensitivity, inflammation, and shared neural connections. This goes beyond the concept of referred visceral pain. Here, Loya et al. State that visceral pain and pelvic floor dysfunction are common in functional GI disorders and chronic urinary conditions. Pelvic organs share sensory neural pathways, meaning that the messages going back to the brain from the bladder will converge and travel with the messages from other pelvic organs. So sensory stimulus like pain from one organ can translate as pain from a different organ when the message gets to the brain. We see it in this rat study that bladder contractions increased with irritation of the colon, showing that something that affects the colon could theoretically affect functionality and sensation in the bladder. And finally, visceral cross-inflammation, the concept that inflammation in one pelvic organ can affect other pelvic organs. And in practice, we also see this phenomenon frequently in gynecological conditions, like endometriosis, dysmenorrhea, and ovarian cysts, where they tend to flare at the same time as GI symptoms. And then you may also see GI and bladder symptoms occurring cyclically with hormonal changes. Here we'll see how the nervous system plays into everything. We have seen that chronic urinary conditions can contribute to isolation, anxiety, depression, and distress, but the association may work the other way as well. In our non-infectious chronic urinary conditions, a positive association exists between psychological distress and severity of urgency and pain. We also see diminished vagal nerve tone and increase in sympathetic nervous system dominance. And here we see a brilliant and simple graphic from Loya et al. Showing the various feedback systems. Here we see neural feedback between gut brain, gut bladder, and bladder brain. We also see the same connections with inflammation. Then we see the double-ended arrows suggesting that dysbiosis can affect the GI tract and the bladder, and dysbiosis can also be affected by changes in the GI tract and urinary system. Okay, so let's move on to an integrated approach to treatment. Here's how I tend to approach my patients with chronic bladder conditions. It's important to note that assessment and treatment will be different for every patient. The following is a general framework I use to help my patients. And this isn't the only right way to treat, but it is the way I treat urinary conditions, using techniques borrowed from personal experience, from research, and with gratitude from other practitioners. There's nothing terribly unique about my approach, but it can be very effective. And my goal for you as practitioners is to become so confident with assessment and treatment of chronic urinary conditions that you never see your patients again. I want you to put yourself out of practice by being so effective, but honestly, that will never happen. But truly, I do have a huge number of patients who years ago presented with OAB, IC, or chronic UTIs that no longer have symptoms. Or they only get symptoms when they're under stress, or if they overindulge in certain foods or alcohol, if they're not sleeping well. The goal here is to get your patients to a place where when you check in on their chief concern of urinary urgency, they have to think for a minute to remember what you're talking about. I want urinary symptoms to be a thing of the past for your patients, and I know you can be deeply competent in this area. These are not cases that you need to refer out unless it is to a skilled practitioner in pelvic floor physio, or for neuroemotional work, or for imaging as co-management. And if you're listening to this webinar because you are experiencing a urinary condition, know that there is hope. There are things you can do, not necessarily to rid you of a diagnosis of IC, OAB, or CP, but to make your symptoms highly manageable or barely present. And know that there are a lot of practitioners out there that are deeply competent in this area. Taking a thorough and detailed history is going to be the most important thing you can do to serve your patient. And here's a short list of things I include in my questioning. So when did symptoms start? Did they start after a UTI, a GI infection, a period of high stress? If symptoms are consistent with recurrent UTI and came on around the onset of menopause, or maybe during perimenopause, you might have a really simple fix on your hands. Very frequently with a decline in estrogen, you'll see recurrent UTIs because the vulvar tissue goes through a certain amount of atrophy. And this can change the opening of the urethra, increasing likelihood of UTI. In my practice, I prescribe topical estriol nightly for 2 weeks with a maintenance dose a few times a week ongoing. And this can completely resolve menopausal UTIs on its own. I want to know if my patient's symptoms are constant or recurring. Maybe they're cyclical and can be modified by working on hormones. I want to know if there's any degree of incontinence. I want to know if there are any known triggers. I want to know, even on a very general level, without being invasive, if there is a history of trauma, either physical or emotional. Sometimes we'll see these chronic urinary conditions coming on after, say, childbirth or pregnancy with pelvic floor dysfunction. I want to know about any concomitant symptoms, comorbidities. And what I'm looking for here is a lot of GI conditions, gynecological, stress and distress. And then I want to look really closely at history of urinalysis and culture. I want to see every single macroscopic urinalysis report, every culture available to make my own interpretation. I will also frequently run an in-house urine dipstick. And then I am likely to send my patients off for a repeat urine culture or a urine PCR test. Next, I want to know what my patient has tried in the past. Have they been given multiple courses of antibiotics? If so, which ones? What was the response? Were there any reactions? Have they been given a reasonable treatment for ICBPS or OAB or another chronic urinary condition? If they've already been on a protocol for these conditions, I want to know exactly what's been tried so I can modify our approach going forward. And then at any point while I'm working with a patient, it may be reasonable to rerun urine culture or send off a sample for PCR to rule out underlying infections. Usually treatment-wise, I start with a bladder-soothing diet, and this can help determine whether the patient's symptoms are inflammatory or irritation or infectious. Often I'll send them off to try this elimination diet for 2 weeks. The degree to which their symptoms improve will tell us a huge amount about what's going on. So here's the list of foods I offer to my patients. And don't worry about this list. Yes, it is long, and this is actually the short list of foods that may be irritants in chronic bladder conditions. But your patients will appreciate this list and know that this isn't forever. This list of foods is equal parts diagnostic tool and treatment, so use it appropriately. Not everyone will have the same food triggers, but most people will have some food triggers. Estimated around 90% of IC-BPS patients will have some degree of food trigger. To someone really struggling with debilitating urinary symptoms, this list of foods represents empowerment way more than it represents sacrifice and restraint. If you present this list as a powerful tool and source of hope, rather than a daunting task, I promise it will be well received. Now, the increase in contentious issue, and I've seen many patients with bladder irritation who are intentionally withholding water because of urinary frequency, urgency, and incontinence. It may be uncomfortable in the short run, but water will help to dilute the urine, making it less irritating to the bladder lining. And your patient may need to work up to the appropriate volume, but it is worth it for the repair process. In your patients with mild urinary symptoms that simply cannot do 2 weeks on this list, you may see relief by just removing the items in bold. So over here on the left-hand side, that is my very short list. And then again, I send my patients off with this diet for about 2 weeks, and then we reassess. If there was absolutely no improvement, and that's rare, we'll head in a different direction. If there is dramatic improvement, we'll move on to treating GI dysfunction as needed, fixing up the bladder, and recommending complementary treatments. Usually, at least in the milder case, maybe 60 to 80% symptom resolution within a few weeks of this diet alone. And that's how you will know you're on the right track. So if your patient comes back a few weeks later with any degree of symptom resolution from the bladder-soothing diet, it's time to move on to the next steps, clearing up the gut and repairing GI and bladder. If your patient has absolutely no improvement on the diet, you may want to look deeper into infectious causes, work on pain perception pathways, and work on more structural and emotional contributors. So we're going to talk about my general approach to treating GI health. And this will look different, obviously, for every single patient, but the framework will be roughly the same. I like to start by addressing body systems that need support. Generally, it tends to be digestive support, liver, gallbladder, immunity, and inflammation. Maybe thyroid and adrenals need support. I will usually support and build resilience in my patients for 2 to 4 weeks, or as long as it seems like they need to. Now, sometimes you'll find something in the GI tract that should be addressed immediately, like Giardia, C. diff, or another pathogen, and I would begin treating those pretty quickly. Next step would be to address dysbiosis as needed. I generally work in a top-down approach, and I address Candida, parasites, and H. pylori early on, shifting to bacterial dysbiosis as treatment progresses. Immunoglobulins can be extremely helpful during this phase. Biofilm disruptors are usually part of my approach. When it comes to urinary conditions, I'm even more likely to use a binder during treatment than I am with the general population. Really, anything I can do to get toxins and substances excreted through the stool than through the bladder is what I'm going to do. So binders are very rational to me. And then once I'm satisfied that overgrowth dysbiosis is down to a manageable level, and hopefully the immune system is less overwhelmed, I move on to GI barrier repair and restoring normal flora as needed. Barrier repair will play a central role in long-term management of chronic urinary conditions. So usually I'll be introducing some non-fermentable gut repair nutrients earlier in the game. And here's my general approach to GI repair. Honestly, when it comes to restoring normal gut function, you're playing the long game, especially when your patient has had a year's worth of history of dysfunction in the GI tract. I would say 6 to 9 months minimum for gut repair, and it will usually take longer the more dysfunction is present. Diet and lifestyle takes center stage here. We have some gorgeous nutraceutical options for GI repair, and I'll talk about them in a moment, but the GI tract will not repair if the lifestyle and nutrition aren't in place. Supplements are really just the icing on the cake. What I have to offer my patients here is this: whole foods, plant-forward diet with lots of color and as much dietary fiber and fiber diversity as tolerated. High water intake as high as tolerated. Great sleep every night and on a consistent schedule. Daily stress management, reducing stress sometimes to the point of a total overhaul of routine, and no alcohol. In terms of nutrients, here are a few that I found particularly helpful. When it comes to adding in these nutrients early, I usually leave out the fiber and sometimes the more fermentable demulcent herbs, as these can cause GI distress in some people. Everything else here has a place at any point during treatment and will only augment your protocol. Again, I would expect at least 6 months after dysbiosis is cleared up for the GI repair to be in place. Now let's talk about bladder-specific support. To every one of my patients with bladder irritation, I will offer quercetin, pretty high dose, and this will help to stabilize mast cells, controlling histamine release. It's a really nice anti-inflammatory. I'll add in N-acetylglucosamine or other glycosaminoglycans if you can't access NAG. This contributes to structure and repair of the bladder lining. And so I would say those two are my top two interventions with the T that I'm going to talk about in a moment. L-arginine can help increase nitric oxide in the urothelium. An increased nitric oxide can lead to smooth muscle relaxation and can be antibacterial, antimicrobial. Overall, it can decrease IC symptoms in some people. Magnesium can be a great addition. Usually I use the bisglycinate form, and that can help with smooth muscle relaxation. Now, my top intervention for irritated bladder is this botanical tea. It's great for all populations. I use it in kids, adults, the elderly. I have my patients steep a 1-to-1 mixture of corn silk and marshmallow, and I have them steep about 2 liters worth overnight in cold water and drink it throughout the day, usually about a teaspoon of tea per cup of water. Most herbs have affinity for particular tissues. Corn silk and marshmallow have wonderful urinary specificity and are very soothing and anti-inflammatory. On the next slide, I'm going to touch on some other urinary-specific botanicals that you might consider if you're comfortable with botanical use in practice. The next two supports are not staples in my practice, but I would consider using them in the right cases. So potassium citrate has been shown to neutralize pH in the bladder and can provide relief in some cases. You find this in commercial preparations, specifically for IC-BPS and overactive bladder. And now we saw earlier in a study that the hypothesis that bladder irritation is a direct result of potassium leaking through the urothelium. And there's actually a potassium stress test that's used to diagnose IC-BPS. And some of the common recommendations are to reduce your potassium-rich foods. So this really may not benefit everybody. Some people may find benefit from it, and some people may aggravate from potassium. Now, calcium glycerophosphate is available commercially. This is marketed for patients with IC-BPS to be able to take alongside irritating or acidic foods so that they are better tolerated. To me, this could have its place for occasional use, but it isn't a mainstay in my treatment protocol. And really my goal with my bladder irritation patients is to get them to a place in their bladder repair and their gut repair that they're able to eat some of their trigger foods without issues. In addition to the above supports, you may consider introducing supplements specific for visceral nociception or pain perception. And some of my favorites there are butyrate, melatonin, vitamin B5. Now let's move on to urinary-specific botanicals. So I've listed some of my favorite botanicals with urinary and pelvic organ affinity that you may consider tailoring to your patient's case. I've broken them down by action, and I won't go deeply into the specific botanicals, but I'll talk briefly about the different categories. Anti-inflammatory is fairly self-explanatory. These botanicals will help to reduce irritation and inflammation of the bladder tissue. Anti-infective botanicals may be considered if you're suspecting an underlying infection. Say your patient comes in and has a history of negative cultures, but their urine dipstick in-house shows extremely low or extremely high pH, maybe mild leukocytes, blood. Conveniently, a few of the botanicals with anti-inflammatory activity are also potent anti-infective agents. I would use caution with juniper in your patients with more severe symptoms. It is a wonderful urinary-specific antimicrobial, but it can cause some tissue irritation in some people. Now, nervines can help to calm the sympathetic nervous system And this in turn can have action on smooth muscle relaxation. Many nervines can also act as carminatives, which can help regulate smooth muscle contractions. Next, we have our smooth muscle relaxants. And these, the ones I've listed here, have urinary and pelvic organ specificity. They're really lovely botanicals here. So these can be really helpful in any of your chronic urinary conditions, but especially in overactive bladder. And then demulcents are your soothing botanicals. Now here's a really powerful TCM patent formula that I've used in the past, and it can be wonderful in the right cases if they match the TCM picture that goes along with it. So note that uva ursi, yarrow, and hatunia are really our powerhouses when it comes to anti-inflammatory and anti-infective. They are in both groups. Combined with a smooth muscle relaxant, a nervine, and some demulcents, you could create a really effective combination for symptom relief. I like to keep my formulae fairly simple. So if I were to make a formula for a patient, say with IC, with urgency, frequency, and pain, I would make a tea with 2 parts corn silk, 1 part marshmallow, 1 part uva ursi, and 1 part hatunia. I may complement that with an evening tea with wild yam, valerian, chamomile, kava, linden, and skullcap. And that would be a really nice botanical combination. Supportive therapies will be extremely helpful in your patients with more severe urinary symptoms. I'm going to go over these very, very briefly, but know that these play a huge role in your patient's recovery. So milder cases are often manageable with nutrition, lifestyle, and basic supplements, but your more severe cases and your patients with severe symptoms are likely to be multifactorial and quite complicated. In these cases, I refer carefully to practitioners that I know are really skillful. My 3 most common referrals in these categories are pelvic floor physio, acupuncture, and a urogynecologist, or a urologist or gynecologist if urogynecology isn't available in your area. I do practice trauma work and emotional work in my practice, but if you don't, then these would be other skilled professions that you would want to co-manage your patient with. So on to cases, and it looks like we'll probably have time for 1 case. So this was a patient that came to me through a consult who had a multi-year history of interstitial cystitis, no cystoscopy. Symptoms were urgency, pelvic pain, frequency of urination, burning on urination, which is not really a classic IC symptom. This patient also had SIBO. So she had 3 positive lactulose breath tests over 2 years. She had been given what sounded like very reasonable treatments for the SIBO. I want to say there were 2 rounds of natural treatment, botanicals, and 1 round had been rifaximin, I believe neomycin, biofilm disruptors in all the cases, prokinetics in every case, and yet she still had symptoms. At times she would get to 80% symptom resolution of her GI symptoms, maybe partial resolution of interstitial cystitis symptoms, but had persistent gas, bloating, and loose stools. And so one of her SIBO breath tests was actually right before this GI map test was run. So let's take a look through the test and I'll show you how I interpret it in the context of SIBO, but we're not here to talk about SIBO, we're here to talk about IC. So in the context more of IC, but a little bit about SIBO. So here's the first page of the GI map. This is the pathogen page. Here we see 1 finding here, E. coli 0157, which can be found in the urinary tract in rare cases. So that is a uropathogen. I've got my eye on it. It's not out of range. We're looking in the hundreds here at the E2 level. Our range starts at 1,000. And so that's all we see on the pathogen page. So not too much heavy growth there, but 1 organism of concern. She did have a robust H. pylori population here, and this is a level that I would treat. So at 1,000 for our reference range, we're flagging 5% of outliers. So she is in the top 5% of the population here with H. pylori. No virulence factors. These are single genes that can be found on the genome of H. pylori that can code for different nasty things that H. pylori can do. Now, normal Flora here, she doesn't have the signature deficiency pattern that we talked about earlier. Her Faecalibacterium is fine, her Clostridia class is fine, her Escherichia are just fine. She does have some overgrowth here that is consistent with SIBO though, Enterococcus, And we saw earlier that I believe it was in chronic prostatitis that Enterococcus populations in the gut had a correlation with urinary symptoms. So she obviously does not have chronic prostatitis, but Enterococcus could still be a urinary risk factor. This is one of our uropathogens, another uropathogen here. Now, at the population level, she's got an excess of the Firmicutes phylum, a deficiency of Bacteroidetes. And so two things I think of when Bacteroidetes phylum is low. The first thing is gut lining. How healthy is the mucosal production, the health of the epithelial cells? Because Bacteroidetes do rely heavily on that nice healthy mucosal layer. And another thing I'm thinking about is fermentation. So we already see some overgrowth here. We know that she's got a history of SIBO, which is fairly classic for carbohydrate fermentation. And with carbohydrate fermentation comes acid production. With acid production comes a deficiency of some organisms, including the Bacteroidetes. So I'd be thinking about that as well as a function of the dysbiosis. So moving on to the opportunistic bacteria, here we see heavy growth. And so when we're talking uropathogens, we've got some here. We've got Pseudomonas, Staph, I would say Staph genus. I'd be more concerned with Staph aureus, not so much. Now Klebsiella, another uropathogen, and Candida. So we've got quite a few possible uropathogens here. In this patient, if she weren't getting better within 2-3 months, I would be sending off a sample for PCR testing of her urine. And you could do that right off the bat if you wanted to see if any of these organisms are also in the urine. But here we see also organisms that are classic for SIBO. So basically all this red growth here, Klebsiella and Candida, are likely to preferentially colonize the small intestine. And with stool PCR, we're actually able to see organisms from throughout the GI tract, whether they're viable or non-viable. By the time they reach the stool, we can see them, and these are quite large populations. So dysbiosis like this is likely to have an effect on the gut lining, on the bladder lining. So in terms of LPS producers, we've got Pseudomonas, Klebsiella, Fusobacterium as pretty potent inflammatory organisms. Klebsiella is one of our potential histamine producers. Pseudomonas and Candida are some of our potential histamine release inducers. So yeah, a lot of these organisms could be predisposing to bladder symptoms. Now I've skipped over the parasite section here because there wasn't anything on it. So you can take a look at the GI map and what it looks like, but I didn't want to pull in anything that wasn't useful. So here under intestinal health, we see one finding here flagged low. That's our secretory IgA. Now this is our innate immunity associated with the gut lining. And when this is low, I am suspecting gut lining issues. Often I'm suspecting decreased health of the epithelial cells, but I'm also in the short run thinking about supporting the immune system. So for her, I would give immune support. I would probably give immunoglobulins, and in the long run, I would be healing of the gut lining. I'd be healing the bladder lining. Now here, digestion is not flagged, but my most optimal finding for steatocrit is less than detectable. This is fat in the stool, and I don't really like to see any of it, but this isn't really a problem, but I'm looking at it. I'm thinking about optimizing function, and then elastase I want to see at 500 and above. Beta-glucuronidase is approaching range, but I wouldn't focus in on that. She didn't have marked hormonal symptoms. Now I've moved backwards. And so that's the end of the test. Now a treatment approach in 1 minute or less, because I'm running out of time, I would support systems. So for her, digestion, liver, and immunity. I'd do that for 2 weeks, maybe 4 weeks. And then I would treat her dysbiosis. I would start with H. pylori and Candida at the same time. My bacterial targets would be the O157, Enterococcus, Pseudomonas, Klebsiella, Fusobacterium. And then next steps would be to repair GI lining, restore motility, support normal flora. And actually, in this case with IC, I would be adding in my bladder-specific interventions right off from the beginning. I'd be adding quercetin, I would be adding binders, I would be adding all sorts of things to bring down potential histamines. I'd be adding biofilm disruptors. And so here's what I did. Bladder soothing diet, didn't wait 2 weeks. Supplements I used were a broad spectrum digestive enzyme with pancreatic and brush border, an immunoglobulin, liver support. I won't go deep into that. You can read it later. For bladder-specific support, quercetin, NAG, L-arginine. I gave her a phage-based probiotic, H. pylori treatment, Candida treatment. I believe I chose a prescription Candida treatment in her case. Antimicrobials, I added biofilm disruptor and a binder. And then the other I will leave. So I'm done with that case. We're going to skip this case and move on to questions. I think I've said all I want to say here.
Thank you so much, Amy. Yes, we have time for a few questions. Our first question, does coffee cause or contribute to OA?
Yeah, I would say it definitely can. And I would say of my patients with any degree of bladder irritation, coffee is the one thing that most people struggle to add back in. So most of my patients, when I see them maybe a year later, they're feeling a lot better. They say, yeah, I just don't drink coffee anymore and my life is okay. You know, it's been better, but it's okay without coffee. Every time I have coffee, I have irritation. But yes, it can contribute, not in every patient, to overactive bladder.
Thank you. Our next question, is there a commercially prepared botanical tea, 1-to-1 corn silk / marshmallow available?
Probably not exactly those, but there are. I have seen urinary teas available. I have a local shop that makes it up for my patients. And you could use just corn silk. If you found corn silk, people can find that. But yeah, I'm not aware of one, but there probably is one.
And what kind of time frame should I expect for treatment of IC?
Yeah, great question. Okay. So yeah, within the first few weeks with the diet, often we'll see a large improvement. I would say within the first 3 months, you'll see the majority of your improvement, with kind of the rest of improvement lagging over the following 3, 6, 9 months. So you'll see a front heavy improvement in IC overactive bladder patients. And then some cases will be more complicated. Some will take co-management and will have a lot of, social emotional factors, some physical factors that will have to be taken into account. And then sometimes when people have long-standing gut dysfunction, bladders, long-standing patterns of pain, it's hard to break through those. So you have to change kind of the afferent pain reception and work on that as well. So that could take a bit longer, but generally I see the most improvement happening in the first 3 months and then kind of a gradual improvement after that. But usually, by a year later, hopefully not many symptoms or a significant decrease in symptoms.
Well, thank you very much, Dr. Rolfsen. We are just about out of time, and I want to thank you for your presentation today. And I also want to thank all of our attendees for taking the time out of your busy day to join us. Again, this webinar was brought to you by integrativepractitioner.com and sponsored by Diagnostic Solutions. Thank you all, and have a great rest of your day.